Hello, everyone, and welcome to another great webinar series presented by Imbed Biosciences. I'm your host today, Brad Wiggins, the VP of Clinical Affairs, and today I've got my guest, Sean Griffin from Ellis and Bodenhausen Orthopedics. Welcome. We're excited to have you.
It's great to be here. Good evening
Thank
from Kentucky.
That's good. I love it. Good evening from Utah. We are going to be highlighting today reducing the SSI risks in high risk orthopedic surgery patients with our SAM technology. We've been excited to have you using it, and I'm sure our audience is also very excited to have you getting to highlight some cases today. So I'm going to turn the time over to Dr. Griffin, and away we go.
I'm Dr. Sean Griffin, orthopedic surgeon with Ellis and Bodenhausen Orthopedics, Louisville, Kentucky. I'm going to talk to you guys tonight about Surgaflex, my experience with it, its applications, its uses, and what it does for me, my hands, my disclosures. As you can see, I'm an advisor for Imbed Biosciences. So what we're going to talk about is reducing surgical site infection risk in high-risk orthopedic surgery patients with the Surgaflex SAM technology. So the healthcare burden for surgical site infections, it's well studied, it's well established, it's well published. It is a substantial burden both financially and, with the impact, on a patient's life. There are, 50 million procedures, inpatient surgical procedures, in the United States every year. 8,000 per hospital annually, and about 3% average, surgical site infection rate in the United States. So you break that all down, it comes down to about $54,000 in costs, and that is, estimated cost that does not, account for the cost, impact of loss of work, lifestyle, all of those, different factors. The infection rates are somewhat higher in a lot of patient cohorts, especially high-risk patients. We'll go through that, as we discuss this, what we would consider high-risk patients for total joint arthroplasty or some of the other, orthopedic conditions in which Surgaflex would be applicable or used. So basically what Surgaflex is, it's a fully synthetic, very thin porous matrix that is designed to mimic the human extracellular matrix. The key feature of Surgaflex, in my mind, that makes it very different than some of the other, competitors and other products out there in the wound care space and things that have been used in this space for prophylaxis against surgical site infection, is that it is microconforming. It actually conforms to the architecture of the wound bed in which it's placed. It is put in dry. Once it gets wet, it becomes adherent. It conforms to all of the tiny nooks and crannies, so to speak, of the wound bed. Soft tissue can be closed over it. You can also use it in an open environment for open wounds. The other key feature of this is that it is antimicrobial. It is silver embedded. It gives 72 hours of antimicrobial properties that is 99.99% effective. And we'll go through that in a slide upcoming about some of the key points of that. So this is how it compares to some of the other types of wound treatments, other devices, other products that are used to help decrease surgical site infections. And you can see, in the left column, the SAM matrix, surgical antimicrobial technology, Surgaflex matrix, how it is far superior to a lot of the other biological matrices. Silver dressings are external only. Negative pressure wound therapy is external only. And all of those have, drawbacks that I can go through, some of which in my experience when we talk about my cases later on. The clinical applications across the surgical specialties, orthopedics specifically, trauma and fracture care, total joint arthroplasty, spine surgery, general surgery, wounds, podiatry, wound care. We'll touch on some of that a little bit later, but I'm going to focus on my specialty, which is total joint arthroplasty. I will discuss some of its uses in trauma and fracture care as we go through some of the cases later. We're going to start out with one of my cases. This was a 73-year-old female, type 2 diabetic, morbidly obese, both of which are high-risk factors for surgical site infection. These are pictures of her at 4 weeks post-op. You can see that she has a rather large leg, but that this incision is clearly well healed, well coapted, minimal residual swelling, no drainage, no erythema, none of some of the issues that you can encounter in a patient like this. The way that I utilize the Surgaflex technology in my high-risk total joints is that once the arthrotomy is closed, either the hip or knee arthrotomy, the Surgaflex is put on dry directly over the arthrotomy below the subcutaneous layer. It adheres to the wound bed. You close the deep subcutaneous layer over top of it, and then you would do your subcutaneous closure. Now, one disclaimer, and it is different. I use negative pressure wound treatment in the form of Prevena negative pressure incisional vac in a lot of these patients that are higher risk. But the mechanism of that and what that is trying to do is very different than what the Surgaflex is trying to do and what its function is. This is a hip patient. This was a 69-year-old male, type 2 diabetes, morbidly obese, very large overhanging abdominal pannus. Anybody who does total hip arthroplasties, obese patients, especially obese males, it's a challenge. You are operating in an area where you are working against the abdominal pannus, and in some of these patients, it can be quite robust. And it does create, a more difficult environment to work in. This area is notoriously covered by the pannus afterwards, where it maintains a high moisture environment. Yeast and fungal infections are common in these folds, and wound infections and wound healing problems are quite common here. When you do these cases, you're also working against the pannus to get the total hip stem down, and you can get a lot of abrasive issues against the skin. And so it does represent a high risk for surgical site infection, wound healing problems. So this particular patient, he's 4 weeks post-op. This wound looks like it, was 12 weeks healed. We used the Surgaflex directly over the arthrotomy. We closed the deep subcutaneous over it, and then we did our standard wound closure. And again, I did use the Prevena negative pressure incisional wound vac in this patient as well. So how exactly it works, just to kind of summarize it, it is put in dry. Upon contact, it conforms to the microcontours of the wound bed. It is transparent. In some wounds, open wounds, wound care, that's very important. You can actually see what's going on. You can make sure that there's no fluid collecting. You can make sure that there's no purulence developing. You make sure there's no tissue necrosis, so you can actually see how the wound is healing. This does facilitate a moist wound healing environment and allow cellular growth. We'll touch on this a little bit more in a couple of slides. Because it does conform, it potentially helps prevent voids for bacteria to proliferate, exudate, fluid to pool, less fluid, less exudate, less culture media, so to speak, for bacteria to grow, especially in that critical 72-hour period after surgery. The antimicrobial feature is very important. It lasts up to 72 hours. 99.99% effective. And here's that slide that kind of shows there's a couple of different species of bacteria, some of the most and fungal pathogens as well. These are some of the most common encountered in surgical site infections, not just in orthopedics, but across the board. And you can see some of the big ones: MRSA, MSSA, VRE, Pseudomonas E. coli, to name a few. And you can see the the blue line is at 24 hours, the gray line is at 72 hours, and you can see the CFU reduction in these for these specific strains, and see where the 99.99% reduction rate, actually applies. So again, one of the key features of this, that it is microconforming. Part of what it does is it helps fibroblast proliferation, signaling ingrowth, adherence, which helps the wound, heal faster. And as this conforms to the wound bed, it also delivers that antimicrobial technology to the wound crevices and the deep tissue, which will prevent or can prevent pooling of fluid. It gets down into crevices where bacteria may be able to proliferate. And you can see here on this slide how the same technology works versus a conventional. Here's a slide that kind of shows some of the fibroblast proliferation, adherence, that that can occur because the bioresorbable polymers do mimic what the body has in its own, extracellular matrix. So a couple of case series with this. One of the case series that was done, and this is in the foot and ankle surgery diabetic uh, foot and ankle series, looked at 22 patients undergoing foot and ankle surgery where they applied the Surgaflex in these cases. They had 100% heal rate, 0% infection rate at both initial and follow-up study, and zero adverse effects in this particular study. Now, the drawback is it is a small case series, but the results are certainly promising. And we're going to talk about another study that was done, which is a much bigger patient population. This was one that was actually done in my own hospital system here in Louisville, Kentucky. This was an orthopedic specific study where they looked at a cohort of high-risk patients undergoing primary total knee and total hip and revision total knee and total hip surgery. The criteria for high risk were patients who are diabetic, BMI over 35, smokers, revisions, and I believe they had a couple other criteria where they looked at rheumatoid, dialysis, anything else, immunosuppressant medication, anything that made the patient high risk. They looked at 100 consecutive patients. They had 0% deep surgical site infections at the 90-day follow-up. They had a few superficial surgical site infections, no reoperation on the joints themselves. And at the conclusion of the study, the deep surgical site infection rate was still 0%. That study is when I became interested in Surgaflex, and that was kind of the genesis for my involvement with it. What we did was we started using it in my hospital for the same high-risk patient population. This particular patient in this case is still probably my greatest success. I actually saw her back in the office today. She's exactly 3 months out, and you would think that she's a year or two out from a total knee. So this is a 6, 7-year-old lady, morbidly obese with severe obesity of the lower extremities. And when I say severe, the picture doesn't really do it justice, but she carries almost all of her weight in her legs. Her BMI was 47 at the time of surgery, and most of that was in her lower extremities. This was one that I had a lot of concern about. I actually lost a little bit of sleep about this one before we did the surgery. I was a little bit nervous because her risk profile was just so high because we were operating, almost 2 inches deep through the skin and subcutaneous tissues to get down to the joint. Surgery went fine. We used the Surgaflex again right over the arthrotomy, closed the deep subcutaneous layers over it. The standard, subcutaneous and cutaneous closure with the staples. And again, I used the Prevena negative pressure wound vac. This patient came back at 4 weeks. She had been off pain medicine for 3 weeks. She had been fully ambulatory for 4 weeks on a cane or less. Her motion was almost 0 to 120 degrees. She has some thigh calf impingement, certainly, but her motion was very impressive. Her x-rays looked wonderful, and there was no signs whatsoever of any wound healing complications. This wound looked better in real life than it did in the picture, and I'm still high-fiving myself to this day over this one, and I am not completely convinced that this would have been possible without the use of Surgaflex in this particular case. This is another one that, was a case that made me a little bit nervous. This is a 68-year-old female, morbidly obese, very large abdominal pannus, overhanging. Her BMI was not terribly high, but she carried it all in her midsection. We did total hip arthroplasty, went well, went fine. She came back at she came back actually 5 weeks post-op, and this wound looked like some of the wounds, previously that I've been doing, 2 and 3 months out. She was completely healed, no drainage whatsoever, no necrotic skin. At the proximal part of this, near that inguinal crease there, didn't have any skin slough, no drainage, no fibrinous tissue, nothing. It was well healed. Again, we used the standard closure for the hips. I used the nylon. It's a better tolerated skin closure device around the hip, especially the anterior hip. The knees, I used the staples. But again, I use the Prevena, which can also help prevent wound efflux and keeps that area dry more than anything so that you don't get that proliferation of that fungal growth in the inguinal crease that you see so often. And you don't keep that moist environment, which macerates the skin there as well. This is another patient. She was a revision total knee, non-infected revision total knee. This was a complex primary situation with a revision prosthesis. I'm sorry, I got this one confused with another patient, same kind of profile. She was actually a complex primary total knee. She had had a prior surgery before, had a lot of scar tissue, had a lot of adhesions, and she had a pretty complex deformity. She was type 2 diabetic, relatively well managed, but still certainly a high-risk patient. This patient did extremely well. We did her surgery through pretty standard incisions. She required a little bit more extensile approach just due to the deformity, due to some of the scar tissue that she had. And we had to use a revision prosthesis because we had to use augments on the tibia. There was some hardware that needed to be taken out. That was another reason why we extended the incision, but certainly high risk for wound healing complications. We used Surgaflex again directly over the arthrotomy. For her, she really wanted a subcuticular suture. She was not very swollen at the end of the case, so we went ahead and did that, and she healed extraordinarily well. We were able to use I use a skin glue, a Dermabond, and I usually use a Stereostrips glued to the skin. It's kind of my own non-patented closure technique, but it works pretty well. Keeps these wounds from draining. This, again, looks fantastic. This looks like a 3-month post-op surgical wound at only 4 weeks post-op. This is another case. This was the actual revision that I had, the previous one confused for. So this was actually an 81-year-old female. She had a prior total knee arthroplasty. She had become loose. She developed global instability. The decision was made with her to revise it with a hinged prosthesis for maximum stability. So again, back through the same, surgical scar, high risk because it's a revision situation. With her, we did use the staples. We did use skin glue with her. We did not have to use the negative pressure wound therapy. And again, this is her 4 weeks post-op with an incision that looks like it's 8 to 10 weeks out. Never had any problems with her. She regained her motion very quickly. I just recently saw her. She's almost 5 months out now, and she's still doing extremely well. This is a complex patient. She's had multiple surgeries on her knee. She had a previous high tibial osteotomy, and then she had a unicompartmental knee arthroplasty, which failed, and she had to go on to be revised to a total knee arthroplasty. So with her, she had extensile incisions that went down almost to her mid tibia, which was of course some concern. Incisions, previous surgical scar, just right over the tibial crest, right over the subcutaneous portion of the tibia where there's literally nothing but skin, fascia, and bone. Those are areas that are notoriously, difficult for healing in certain situations. With her, extensile incision, we had to remove the hardware, total knee arthroplasty, use the Surgaflex throughout the entire wound bed. Did extremely well. 4 weeks she came back. We took out her staples, put the Stereostrips on here. Her incision looked great. She's never had any problems. Certainly no wound issues or anything in a patient who was certainly high risk for that. This is another patient. This unfortunate lady was visiting her friend in the hospital in the ICU and tripped on the floor and fell and fractured her femoral neck. She was a morbidly obese lady, large abdominal painus, type 2 diabetes, and she had an autoimmune peripheral neuropathy that required occasional uses of steroids, immunosuppressive medication. She wasn't on anything at the time, but again, still a high-risk environment. And she also fell in the hospital, which, puts you at further risk for colonization and things. So we did a total hip arthroplasty for her fracture. We utilized the Surgaflex. We were able to close this with subcuticular suture, topical skin adhesive, and she did extremely well. Again, this looks like an 8-week wound. She never developed any skin slough, no maceration in the proximal portion around the inguinal crease, and did exceptionally well after her surgery. This was her only 4 weeks out. Pain Guard. So I'm going to touch on Pain Guard. My disclosure with this is I have not yet used Pain Guard, but Pain Guard is Surgaflex embedded with lidocaine, which further increases its, I guess, potential uses. I'm going to go over a couple of slides showing patient studies with this. These are not my cases, that is my disclaimer, but I'll kind of highlight this. This is a patient this is a patient with a super obese patient with BMI 56. She had to use a general anesthesia. She was undergoing a procedure for osteomyelitis, the distal tibia, and a fibula fracture. Obviously, this is a very high-risk situation. She could not get a block from anesthesia due to the extreme size of her leg. This was one where the wound could not be fully closed. They utilized the Pain Guard, the Surgaflex with Pain Guard. Double whammy here, so to speak. You get the wound care aspect of it, the antimicrobial aspect, and you also get the pain relief. She had another incision on her knee. That was the only pain that she complained about at 6 hours afterwards. No pain in these distal incisions where the Pain Guard was utilized. This is another case, a foot and ankle surgical case, neurolysis of the common fibular nerve and superficial fibular nerve for pain and paresthesias. This was another one where the Pain Guard was utilized and the patient reported no significant pain issues after this, and especially with neurolysis procedures, there's higher risk for neuropathic type pain, for nerve-associated pain, and certainly a good application for the lidocaine portion of the Pain Guard, the Surgaflex Pain Guard. There's actually a video of the Pain Guard being applied in this case. The difference between the Pain Guard in color is that it is translucent and clear. You can't see that so well with this video. It does wash out a little bit. There's a little bit better view of it right there. The Surgaflex is orange colored. I call it mango colored. My OR staff calls it the mango, which is a clever euphemistic way to describe it. But this is it being applied just above the perineal nerve here in this video, which you can clearly see. Bunion surgery. Oh, I'm sorry. Back to this slide again. This was reported pain in this particular patient. On a scale of 1 to 10, before surgery, pain 9 out of 10, 45 minutes after 0, and 3 hours later a 2. So obviously a big reduction in narcotic use as a good potential for this particular product, which can really expand its uses for other things that we'll touch on here in a slide or two. Here's another foot and ankle case. This is a bunionectomy. This was another surgeon who performed this, a foot and ankle surgeon. The Pain Guard was utilized here with a primary closure over it and was reportedly extremely successful in this patient. The bunion is notoriously painful surgery. A lot of the other products that have been developed in the space, particularly Expro, which is a depot local anesthetic. All the studies and original approvals for the FDA were done in bunions and bunionectomies. So there's been a lot of time and research spent on these. This is it being applied underneath the incision after this extensile incision on the foot. This is the patient's reported pain afterwards, 6 before, 0 45 minutes, and 0 for 3 hours. This surgeon reportedly called in to tell us how effective it was, and he was pretty giddy and excited over the results he was getting from these in the bunionectomies. This is the dosing chart for the for the Surgaflex pain guard, obviously lidocaine needs to be body weight dosed. This is available with the product when it comes. This is a good reference that's easily accessible, so you can know exactly how much you can put in. For most patients, at least in the orthopedic, the 4 by 20 centimeter is fairly well tolerated, and they should not run into any significant overdosing with lidocaine issues. There's also Shield, which is another product that is also with Pain Guard now for wound care. So here's the key takeaways. Fully synthetic, porous matrix designed to mimic the human intracellular matrix. It is microconforming. It adheres to all of the wound crevices, which has great benefit over some of the competitor products. The antimicrobial properties are another key feature of this. 99.99% effective reduction in antimicrobial propagation at 72 hours. The pain guard, the addition of the lidocaine to this has great potential in the future, especially for use in bigger orthopedic cases. Geriatric hip fractures would be another big one where there's a lot of focus in reducing narcotic use because of some of the side effects of delirium. And this, again, has a very long track record and successful use in the wound care space. And we're trying to carry that success into the orthopedic surgical space now.
Outstanding. Thank you so much for highlighting all of those cases, Dr. Griffin. I think one of the most standout things for me was the amount of cases that you shared. You've been having really lovely outcomes with your patients with this product, and I think you highlighted a lot of different types of the patients that you encounter, and I think high comorbidities is what stood out to me.
Yeah. Yeah, I mean, so I continue to use this. This was my first case series that we did and we tracked and followed that are now all of them over 3 months out. We continue to use it. Patients continue to come back to the clinic for 4, 8, and 12-week follow-up. I have yet to see any significant issues. There was one patient who did develop a seroma. She is a high complexity patient. She was a fall in the hospital, had a femoral neck fracture, got a total hip. She has a lot of other factors going on. Never developed an infection. She did develop a seroma, which we did have to debride, but it was not a failure that I would relate to an infection or wound healing complication because her wound healed great. There was no evidence of infection. It was other medical comorbidities that led to that. Outside of that, I'm probably around 25 cases now, and I've yet to have one single surgical site infection associated with it.
That's great. I think as everyone in the ortho community can comment on that's listening to this, obviously the concern for long-term outcome and following your patient for many months after and ensuring that you're not having returning infection in those revisions especially is really become a highlight and something that's very important to the patient and ultimately to the entire ortho community. I was just wondering, can you highlight a little bit for the audience what your basic standard algorithm of care is for how you treat a revision from an infection control standpoint, maybe how you manage going into the OR, and also how you manage maybe once you begin to replace and clean up and start to move out towards closure.
Yeah, sure. So I will address the aseptic revision, meaning it was done not for infection, it's done for failure of the arthroplasty. Sometimes periprosthetic fractures, the distal femur, you're doing a distal femoral replacement. But whether it's a total joint or total hip that has failed, I kind of have the standard treatment algorithm. So for aseptic revisions, once you're done with your case and you're moving to closure, a lot of people out there utilize vancomycin powder. They use vancomycin beads or antibiotic impregnated resorbable beads. I do not use those routinely in aseptic revisions, in revisions done for reimplantations after infection. It's a case-by-case basis. Single stage washouts, polyethylene exchanges. I typically would use a vancomycin powder or an antibiotic bead more often in those cases, usually in the suprapatellar pouch or the deep layers, in a hip. Aseptic revisions, I really don't do that on a routine basis. I've never seen any really good convincing data that says you have to do that on a routine basis in an aseptic environment. So I really focus on the arthrotomy closure and what goes afterwards. So my standard arthrotomy closure is I use a heavy interrupted vicryl suture to start, which is usually number 1 vicryl that reapproximates it, and then I use a heavy running barbed suture such as a Surgaflex or a quill. Now, in revision cases where there's been some laxity of the capsule, they've had some subluxation of the patella where you get this kind of stretched, capsule, something that would be high risk for arthrotomy failure. I will, on occasion, use a heavy non-resorbable suture, such as a max braid or a suture tape or a fiber wire, because you don't always want to use a resorbable suture in those cases. Once the arthrotomy is closed, that's when I move to the Surgaflex. Now, in the past, I've used some of the competitors. I've used Celerate. I've used Kerecis. Used Celerate extensively for a while. Started to have issues with it. The powders, they would kind of congeal. You would get wound efflux. They would kind of create this slurry, so to speak, and I started seeing a lot of drainage. And when I started using the Kerecis as well, I would start seeing some of the drainage with that. I personally abandoned using Celerate and Kerecis, and I know some people are still using it. So when Surgaflex came along, it was this kind of a serendipity moment that says, this is not going to cause drainage. This is a solid that adheres to the tissue. It conforms to the tissue. It's not a powder. It's not going to congeal with any drainage or any efflux that's going to come and create a drainage scenario or a fistula that could develop between the joint. I always want to get a good deep subcutaneous closure over the Surgaflex, which I lay right along the arthrotomy. I've had once or twice where I've used more than one sheet where you kind of curve it around because arthrotomies tend to be, medium parapatellar. The deep subcutaneous closure over it, I think, is important because I like that to adhere to the tissue both below the arthrotomy and above that deep subcutaneous layer, because I think that the integrity of all layers of the closure are very important. Then we move to the subcutaneous closure, which is typically an interrupted vicryl suture, then followed by whatever skin closure. Most of my revisions in knees get staples. Most of my revisions in hips get suture. A nylon suture is better tolerated around the anterior hip, especially, in the inguinal crease, especially in a bigger patient who's got, a larger abdominal pannus overhanging. And I do utilize the negative pressure wound therapies, the Pravina wound vac. I typically use those in morbidly obese patients, where there is a large adipose tissue layer that is high risk for fatty necrosis and wound drainage and these other factors. If it's a reimplantation scenario where you're a little bit more concerned about infection, even in a normal sized patient, I'll typically use a negative pressure wound therapy as well.
Great. That's a really thorough explanation. And I think it's important these days to highlight with other providers that are listening what your techniques are and what's working for you.
Sure.
You shared many successful cases here. And I think that that's one of the most important things that we can continue to carry forward throughout the ortho community is really what algorithm of care looks like as the country, really the ortho community continues to work towards the idea of some type of standard of care treatment when it comes to these types of procedures. So really excellent talking with you today, Dr. Griffin. Thank you for your time. We're excited for you to be able to share all of these great cases with the audience. And thanks again for your time today. We'll look forward.
I really appreciate it.
Yeah, we look forward to hopefully having you on a future webinar. And if you're listening live, thank you so much for joining in. And we will see you again on the next Imbed Biosciences webinar. Thanks for joining us today.
Thank you, Brad. Thank you, everybody, for tuning in. Yeah,